Dr. Sham, I wanted to start with you. Um, I want to start by understanding what is suicide and why do people do what they do.
Sure. Deepika, firstly, I'm glad we are having this conversation because, as you said, we tend to not talk about suicide or speak about it in hushed tones. There's a lot of stigma and even fear about discussing this topic. And yet, we know that this is probably the largest public health crisis we are facing, maybe the world is facing, certainly India is facing that. And the statistics tell us, that this tragedy happens close to 1,000 times a day in our country. When someone who's prominent dies from suicide, there's obviously an outpouring of confusion and grief, and everyone asks this question. But I just want to remind ourselves that everyone is a hero to their family and to people who love them, and that we are losing 800 to 1,000 people every day, and many of them between the ages of 15 to 25. We know from data that worldwide, in the age group 15 to 24, suicide is the leading cause of death. And in India, for the ages 15 to 39, suicide is the leading cause of death, which means suicide is taking away our youngest people, which is, of course, a tragedy on so many levels, a loss of their life, trauma to the family, and a loss of economic manpower and for our country and our society. And yet, as you said, we are here in a strange situation where, despite the fact that it's so common, we seem not to understand enough about it. And any psychiatrist, any mental health professional who's been watching the recent dialogue online, on social media, or on TV, the coverage of suicide, knows that obviously there's still a lot of misconceptions. Now, when someone dies from suicide, meaning they take their own life, people ask why. And in this particular in this recent case, people asking why this person seemed to have everything. Why did they die from suicide? And the implication of that question is that there must be some life event that understandably led to a situation where this person felt that life was not worth living. But that's a very simplistic kind of perspective of suicide. And firstly, I want to remind people that think of suicide as the final fatal outcome of an illness. And asking why did this person die from suicide is like asking why did this person die from a heart attack? What led to the heart attack? Of course, the analogy is not exact since the brain and the heart are different organs. But it's similar in that, let's say somebody goes out for a run. And during the course of their run, they happen to have a heart attack and they die. To ask the question why, we're not going to blame immediately saying that the run caused it or that exercise caused it. We will understand that the heart attack was a result of multiple factors that had probably been operating long before this event. The person's cholesterol levels, their smoking, their high blood pressure, their diabetes, their stress. And one fateful day, the heart was stressed enough that because of pre-existing blockages, blood supply couldn't happen and the person had a fatal heart attack. Now, suicide, we have to start thinking of suicide like that. In other words, what are the risk factors that can increase the person's vulnerability to suicide? And we know this. By the way, I must say a couple of things. Firstly, that obviously there's still a lot that we still need to learn about suicide. Okay. But having said that, we do know a lot of facts, and these facts need to be out there for the public. And the first thing is to know that it's a complex condition. Secondly, that there are many variables that go into it. And I can expand on these variables. Broadly, they are variables that are individual, that are internal,
So that was
variables that are
that's
social.
the next question I was going to ask you, which is it specific to events? And there is a tendency to say, oh, this person's business wound up, or the failure of a movie, or bad grades, after an examination. So how relevant are these instances or these specific episodes or events in eventually the person doing what they do?
Sure. Now, this is a good question and a bit nuanced, okay? Because Firstly, I want to emphasize that it is rare that you can attribute a direct cause correlation between the life event and the death from suicide. But we do know that stressful life events are stressful. They provoke emotional anguish, and depending on the vulnerability of the individual, it depends whether or not they're able to cope with the anguish. But first, let's just define what happens at, what is the state of mind of a person who is on sort of the edge of suicide. What happens, the state of mind is a person is feeling extreme anguish, extreme pain, emotional pain. They feel despondent, often helpless and hopeless. And there's so much emotional pain. And during that time, often the thought processes are affected. So they're not able to think creatively. So it seems like all options are closed. My life is really painful. Whatever it is that I want, I cannot foresee that I'm going to get it. My mind is not working clearly. I cannot even think of alternate possibilities. And I'm in such excruciating anguish and pain. And because of that, I feel alone, because the issues that have caused this compounded by creating loneliness and isolation. So in this feeling of anguish and isolation and pain and lack of any alternate possibilities, the mind can't think about it. A person then feels that stopping this, ending this, will, however scared I am of dying, will be preferable to the anguish of life. And that's important to remember. It's not like there's a death wish, but more that there is such excruciating pain in their minds, in their lives, that death seems like the only option. Now the question is, what brought this person to this point? And here, it's almost as if every individual has their own mix of variables. But broadly, you can think of two kinds of suicide. Firstly is the sort of premeditated suicide, where a person has been feeling a certain way, feeling despondent for a long time, usually has a mental illness that has not been diagnosed, either anxiety, depression, bipolar disorder, multitude of illnesses. And the person finally gets to a point with this emotional anguish, which nobody else can understand, because all too often we don't understand this, results in suicide. On the other hand, you have the impulsive kind of suicide, where a person seems reasonably all right, and then some acute crisis happens, some life event happens, and they don't know that they have this vulnerability that's not been tested per se before. And suddenly this confluence of...
What do you mean by reasonably okay? So my question is, is it possible to take your own life without having any form of mental illness? Is dying by suicide directly related to mental illness?
I think what we all have to understand is diagnosis in psychiatry does not have the same real status as a diagnosis in medicine. And by that I mean, we have
the reason I ask this is because some of the health officials, there was this sort of comment going around that while the cause of the death is known, an investigation would be done to understand whether the person suffered from clinical depression.
Right.
And my understanding always was that the two are interlinked. You would not do something like that if you weren't suffering from a form of mental illness.
Yes, that is the reasoning that... so there's a debate, because if you look at the literature, and if you look at literature that comes from the West, they find that at least 90%, if not more, of people who die from suicide had, when we do what is called a psychological autopsy, which is trying to find out the state of mind of this person and their psyche before
and
this.
So that is possible. A psychological autopsy so basically that is something that can be done on a body.
Well, keep in mind that it's not as exact as actually talking to a person clinically before the event. But having said that, one can deconstruct the events of what happened, get information from other people, from family members about their behavior, look at any, writings and so on, get a sense of their state of mind. Right? So that's... So
what is the kind of information that one can get from the brain itself or from the mind itself?
No, a couple of things here. One thing I want to clarify, when you ask, the question is, does everybody or many people or most people who die from suicide have a mental illness or not, is the first question.
Right.
Here we must understand that mental illness is itself a diagnosis made on a list of symptoms. We don't have a test. Now, when you look at those list of symptoms and study the population from Western data, from America and the West, the research shows that 90% or more of people who die from suicide do have a mental illness. But if you look at data from Asia, from India, from Asian countries, that number falls to 40 to 50%, meaning 50% of people did not meet criteria of a mental illness. But as you said, the idea that someone would take their own life without a pre-existing issue, I mean, that is sort of the presupposition that in this situation, because there such an act resulted, ergo we say that there must be something happening with the mind that caused that. But it is not. In many cases, it's not clinical depression. It could be something like a lifelong inability to handle impulses, to deal with frustrations. That is not a major depressive disorder, but that a person may have trouble controlling their own impulses, managing their own feelings, but they have managed in life until one day something happens or an accumulation of events that breaks through their defenses. They're unable to control that impulse. And that's the key point, that 50% of people who die from suicide in India, and probably a significant percentage in the US as well, die impulsively. Meaning that if somehow we were able to avert that time, that 5, 10, 15, 20 minutes when they were in this frame of mind, which we call acute suicide crisis syndrome, it's just filled with anguish and inability to think clearly. If we manage to save them during that time, either through a helpline or through making sure they don't have access to lethal means and so on, we can actually make an intervention in this cohort of people. And in the first subgroup of people, those who have had long-standing issues, we need to sort of detect depression, anxiety, and mental illness more so that we can treat that. And by treating that illness, we can make a big difference in suicide prevention.
Is it hereditary? Is it biological? Is it caused by events in their life? Is it one instance that can cause it? Is it a combination of multiple things?
You know, as a psychiatrist, for me, and I'm sure a lot of mental health professionals share this, you know, everyone wants a straightforward answer. We want simple, easy to understand solutions. And the problem with mental health is it is quite nuanced and there are multiple factors. Genetic factors are definitely a factor in both depression and suicide. We know, for example, that if someone has a first-degree relative who dies from suicide, they have a higher risk than the general population, 2 to 3 times the risk than the general population. We know that in twin studies, when twins are separated at birth and we study suicide rates in twins, there's a 30 to 50% concordance. So we know that genes probably play a role. We haven't identified which genes. We know that early childhood adversity is a risk factor for suicide. People who were unfortunately the victims of child sexual abuse or physical abuse while they were young, many, many years later, that we know that elevates the risk for suicide. We think it might be because of alterations in brain structure and the way the brain processes stress. Having a clinical disorder like depression or anxiety increases the risk by at least 3 times, by a factor of 3. So that's pretty significant. And then there are personality traits like impulsivity I was talking about, frustration tolerance, that increases risk. Substance abuse increases risk. So these are sort of the personal factors. In addition, this then can create a situation. Now it depends on your sensitivity to what is happening in the world and the degree of stress that one is facing.
And so you could that's the environment.
That's the environment. But again, the environment is a dynamic process between the person and the environment. For example, one person may be exquisitely sensitive to rejection and criticism because of their nature, because of stuff that has happened, or because of clinical illness. We're not, all of that can do that. If a person is exquisitely sensitive, they can go into a room and somebody can not look at them or not shake their hand or not smile at them. And that on that particular day, when they're already vulnerable, can hit them so hard that they say, I want to die. They might even pen a note saying, I decided to die today because my friends didn't say hi. Now, in a culture like ours, unfortunately, that leads to a witch hunt, where we start saying, listen, you died, you caused the death because you didn't say hi to this guy. Now, unfortunately, the casual cruelty of life is there for everybody. There is, this happens. It's not that everyone is pleasant to us all the time. I think it's because when people are trying to understand this, they're trying to ask, what would I feel like? They're not understanding that there is an element of what happens in the mind and brain that you don't know what that feels like. Unless you've experienced or work with this in this field, you do not know the extreme anguish, the emotional pain of a person whose life seems perfectly all right from the outside, but because of neural structures, because of the stress hormones in the body, they're in exquisite agony. And that's something I think people don't understand. So they are trying to ask the question, what could have happened that could have pushed a person to doing this? What could it be? Let me as a human being try to understand that. So I know where people are coming from. They are coming from a place of, let me understand this because it doesn't make sense to me at all.
Right.
And particularly we know, for example, that poverty is a risk factor for suicide. We know that deprivation is a risk factor. We know that loneliness is a risk factor. There are social issues that can worsen the risk for suicide. Conversely, we also know that success and wealth are not protective, that people can have, in that sense, everything, just like they can have a heart attack and diabetes while they have everything else in life. You can get clinical depression and suicidal ideations and become suicidal despite having everything else.
And are people like in more in the spotlight in the entertainment industry, film stars, athletes, etc.? Do you think that they're more vulnerable, or the profession or the industry that you're in doesn't have anything to do with it, and it boils down to the individual?
I don't think we have data to suggest that those professions, people or celebrities, have a higher rate of suicide because of the industry. There are some studies that look at correlation between creativity, depression, and suicide, bipolar depression in particular. And there's some interesting studies looking at that. So it is possible that a cohort who is creative also carries with them a gene for emotional distress and anguish. Every industry in that sense has its own stressors. There is no industry today that is without stress. And it is true, by the way, that we have somehow created a culture worldwide where suicide is increasing. There is no denying. There is no denying, for example, in the US, that 50%, there's been a 50% increase in suicide in the last 8 to 10 years. We are seeing that in India as well. So clearly, our genes have not changed. Something has changed in the environment, and there are lots of things that have changed. Above all, I think a society where, and this is not specific to any one industry, any industry today you go to, we are living a life of, the ultimate capitalistic life where people are defining themselves by whether they're doing well in life or not. They are chasing, something all the time. Our lifestyles do lead to impairment in our sleep and often in the diet. It does lead to extreme competitiveness and therefore isolation often, because everyone's busy with their own thing. And that is, I think, a toxicity which has become a fact of modern life. And that is why I think that's a big reason. Of course, there's technology and social media. We haven't covered that. I'm sure we will. There are other factors. But if you ask me, yes, there are cultural factors, not limited to an industry, but representative of the kind of life we're all living in today's world. And
Right.
it is creating a lot of distress, and people who are vulnerable, who have, in addition to all the things we talked about, could reach the situation.
If I was that person that somebody called just before they took their life, if I happen to be that person, if I'm on the receiving end, am I someone, do you think I can tell that they're in distress? And if yes, what should I say or what should I not say?
So, absolutely, a person who has been contemplating suicide, there are multiple things that one can look for. Firstly, of course, is behavior preceding that day, where a person might be withdrawn, moody. You might see someone putting their affairs in order, maybe giving away things, giving away possessions. Talking about death, it's not uncommon and for people who are feeling suicidal to talk about death, dying, or not being there. And by the way, it is not. There should be no hesitation in asking if you feel like someone is at risk. There's some people worry that asking about suicide implants the idea of suicide in the person's mind, but that does not happen. Research is very clear about that. And so you can ask, what do you feel? Do you feel like life is too hard, like you don't feel like you want to live, and that
Yeah,
kind of
because
thing?
I think one of the other things that people feel is like, you don't know when, as either a family member or a friend or a colleague, you come into contact with someone, and sometimes there is this feeling of, am I crossing the line? Am I crossing? Because I think each one of us has this sort of
Boundary.
boundary.
Right.
And I think sometimes people hesitate in saying more than they're comfortable saying, because you feel like you're constantly thinking, I don't want to cross the line. So you're probably going to say, I hope you're feeling okay. Or, just keep it at that level. But at what point do you actually intervene and say, okay, I don't think this person, whether you're a family member or not, I don't think this person is being able to think independently entirely. And maybe this is time for me to take control of the situation.
There are 2 points here. One is the point of intervention should be as early as possible. One should, if possible, not wait until the person is imminently suicidal. One should have, we should have enough awareness that the family is noticing mood issues that predate this issue. I'll give you an example. I mean, this is not uncommon. I'm not sharing any specific details, but to give you a sort of a prototypical example, this person who I see, let's say, she's married, she has kids, and for many months she's been a little bit withdrawn, a little bit quiet, complains of fatigue and tiredness. But because there's no awareness, the family takes her to a physician, they do routine tests, and they say, look, you're fine, it's not a problem, don't worry about it. She continues to do this, but nobody in the family is aware of the degree of anguish. And then finally, one day, they notice that she is being even more quiet than usual. She's saying, she has said goodbye to a few people, and she's starting to give away some things. And at that point, fortunately, the family decides to take her to a psychiatrist. A diagnosis of major depressive disorder is made. The person is treated with both medicines and psychotherapy. A few weeks later, they're feeling significantly better. And that is a typical example of a case where suicide has been averted through awareness.
Right.
So that's the first thing. We want to spread enough awareness that, if there's emotional anguish, and I always say this, look, by diagnostic criteria, we are saying if someone is low and sad and withdrawn or not their usual self for most of the day, for at least 2 weeks, that's the threshold. But people go months and years, and that has to change. So that's the first thing. Second thing, at the acute time, the onus, you see, as someone who doesn't know the person well, it's difficult.
Yes.
It really becomes the responsibility of the family. And it is, I cannot emphasize enough, and I'm sure other panelists will also share this.
Often what happens is you meet somebody socially, you know them, you meet them socially, but you don't know them well enough to say, look, I think you need help.
Well, I'm going to ask you this question, right? What if you see someone who seems at risk for a heart attack? They have diabetes, they're eating sweets, they're smoking, they're overweight, they're not exercising, and when you meet them at a party or a social event, you can see that they're not unwell. Now, unfortunately, yes, that does happen. But you're right, because of, depending on our relationship, it may not be something that we can actually engage with. But what I would say is, firstly, we develop that sensitivity, at least for the people who are near and dear us. We still, fortunately, are a society where every individual, most people in our country still, unlike the West, have a few people who are close to them, few people who care for them, few people who that person listens to. So those people must be aware, and they must work together with the mental health community. Every psychiatrist I know has worked with patients who, unfortunately, the family has said, look, I don't really think you need a medicine. I don't really think you need anything but a little positive thinking. We don't want that anymore, because this is too difficult a problem anyway. We need everyone involved. So that's what the most immediate family has to be sensitized and should stop at absolutely nothing. If there's any sense, any idea, any feeling, any thought that this person has expressed suicidality, take it seriously. All too often people think, it's just a cry for attention. Person is just saying that, don't worry, they did that last month. It's good. We know that when a person attempts suicide, their risk for dying from suicide, if they don't die in that attempt, is as high as 25% in the next few months. So it is extremely high. We must.
And for someone who's thinking on those lines, do they express it, or is it internalized, or is it depends?
It really depends. Many people do express it. Many people express it in covert ways sometimes. They might talk about leaving it all, or just wanting to get away from it all. Wouldn't it be nice, if all this problem wasn't there? So it could be subtle. They may not, though, overtly say, and therefore they should be asked. they should have no hesitation saying, look, I noticed you're withdrawn and you said that. I'm worried. Do you have any thoughts of not wanting to live? Do you feel like you want to not wake up in the morning? You feel like you don't want to live. And at that point, the person, the family member, should take them to see a psychiatrist, a mental health professional.
Right. I think one of the other questions I wanted to ask was when an event like this happens, what does the family go through? What the immediate friends, the family, what are they going through emotionally, and what do they need to do to deal with and hopefully eventually overcome, or at least deal with the loss of a loved one?
I have to say it's one of the most difficult things emotionally, obviously, for family to go through. And depending on your relationship with the loved one, we know that if a child dies from suicide, then the parent has, the mother especially, has a significantly higher risk of dying from suicide. It is an extremely difficult thing because it leaves in its wake a lot of unanswered questions. And what you see in family is sometimes confusion, anger, guilt, and regret. Confusion about bewilderment, about what happened. Why on earth did this happen? Just an unbelievable shock. Then a sense of anger sometimes. Anger with even the person who's gone. How could you do this? How could you leave us like this, And then a lot of second guessing and regrets. If only I had done this. If only I had answered that person's call. And I have worked with people who have been ridden with guilt because the person who died from suicide had just sent them a message and they happened to, as we often do, we don't know. In hindsight, you can say that, right? But you didn't see the message. A few hours later, you hear that person has died. And the enormity of the guilt, because again, the person has to understand, and that's part of the process, that look, this was not a simple thing. It was not you just having to respond that day could have saved this person. It is a complex, multifactorial thing that had been brewing for a very long time. And so there's that guilt. There's also survivor guilt sometimes, feeling that I have survived, that person is not, so I can't even enjoy myself in my own life. And for many people, it needs, especially if it's a parent in particular or a spouse, it will need some work, some therapy to finally come to terms with what has happened, to accept that in some sense, in this particular case, all that they could not have done anything differently.
Right.
And to, like with all grief and bereavement, to finally come to some peace, feel the connection with that individual in your heart. And that's where you come to. But it is a process, and there's no denying that it's very difficult. And that's my point. These are young people who are dying. And every death sends waves, ripples of all of this throughout our society. And, I think, and it's really, to me, shouldn't we all be astounded that we know it's a fact that the leading cause of death for most Indians, because most Indians are under the age of 40, the leading cause of death for most Indians is suicide. This should be on every national headline, every national paper, and we need a multidisciplinary, national level kind of engagement and participation to avert this growing epidemic.
So for the general public, general audience that is watching this, let's say today I'm someone, now I'm aware, okay? Today we're having this conversation. I'm aware about the importance of mental health.
Right.
And I understand that there is a thing called mental illness.
Right.
Now what do? I know it's important. I know mental health is important. And if I am someone who's either experiencing some sort of symptoms of mental illness, or I know somebody, then what am I supposed to do?
I'll try and do this in a simpler way by making an analogy of physical illness. You see, mental illnesses also lie on that spectrum. There is no one mental illness.
Yeah.
So let's use the analogy as, let's say you develop a flu. Yeah. What would you normally do when you get a flu?
Correct.
You probably do some home remedies and you see what happens in 3-4 days. And if it gets better, you forget about it and you say, thank you so much. Okay. But let's say the flu doesn't get better. And then you think the fever is not going down. It's been 2 weeks. You'll probably go to your nearest GP or something.
Exactly.
And say, listen, my fever is not going down and can you treat me? And the GP will probably say, okay, let's try this out for 10 days, 15 days. And then after 10 or 15 days, if things are still not getting better, he does an X-ray and finds out you have pneumonia, he's going to say, listen, you need to go and see a chest physician.
Yes.
So equally in that sense, if you thought of mental health problems in that kind of gradation, then I think people need to ask themselves, where do they lie on this spectrum? Is this something for a home remedy? Is this something that I need to go and see my GP equivalent for mental illness, or is this something where I need to go and see someone like Sham or Anna, a psychologist?
Now let me start exercising. Let me focus on my nutrition. Let me focus on my exercise. Let me speak to a family member. So you would try that for a couple of days.
That's what I meant.
And if that doesn't work, then obviously you'd go to a general practitioner, or if you're showing physical symptoms, or then you would go to a counselor, or you would go to a psychiatrist. And I'd like to hear from you if you can differentiate for everyone watching this, the difference between a counselor and a psychiatrist.
Sham, you were saying you were going to answer that.
Sure. So I think one thing to remember is that psychotherapy is a function, not a qualification. Meaning, a psychotherapist is a person who does psychotherapy. Psychotherapy means talk therapy. And various professionals can do talk therapy, from a psychiatrist to a psychologist to, in America, social workers and so on. The unfortunate thing...
In India, what do we call it?
In India, we call it either counseling or psychotherapy, which is talk therapy. And again, in India, a number of professionals can do it. In fact, in India, we don't have standardization actually for what constitutes psychotherapy and so on. Now, the psychiatrist is a person who's gone to medical college, done MBBS, and after MBBS does an MD, a subspecialization in psychiatry. And ideally, the psychiatrist should have been exposed to the biological aspects, which is what happens in the brain, the different organ systems, how different diseases affect the brain, and also, ideally, training in psychotherapy, which is what are the various talk therapies. The psychologist is a person who goes through the humanities stream, so does a bachelor's or a master's in psychology, maybe a PhD, MPhil, and learns different schools of psychotherapy, but they don't have any training in the brain, in the diagnostic sort of considerations, or in the metabolic considerations. Now, this has resulted in a bit of a fragmentation in our community. There's no doubt about it. And this is unfortunate, because your question is very valid, because it's hard for people to navigate this maze. For example, if I go to a therapist, now there are many good therapists,
Before you say go to, I want to stop you there and say a lot of people don't know where to go and what to do.
No, but the point here is exactly, in an ideal situation, if there were enough mental health professionals around, you would go to a mental health professional who could, through conversation and diagnosis, establish what is biological, what is a disease, what is non-biological, what needs conversation, and so on. But unfortunately, that is very difficult to find because of the way we don't have enough psychiatrists, and a lot of psychiatrists are not, So ideally, if there were enough psychiatrists, my opinion is you would go to a psychiatrist, and ideally that psychiatrist would then tell you whether or not this is a situation that probably needs medicine, or you can do psychotherapy and other interventions. If that is not possible, and that is definitely not possible for many people, go to a good therapist. Even if the therapist is not a psychiatrist, a good therapist understands what their role is, and understands that, look, this is a case where I need to get a psychiatrist involved. And a good therapist and a good psychiatrist work together. They talk to each other, they make sure that they're on the same page, and they don't get into a turf battle, which unfortunately I do see. I do see situations, and I think anyone here will agree, you go to a therapist, sometimes the therapist does not want you to see a psychiatrist because either they have their own ideology or they're afraid that they might lose the client even. Vice versa, a psychiatrist may not have any idea of psychotherapy and may actually just say it's okay, you can do it, or it's not really a big deal, and it's all about medications. So you see, so the short answer, the complexity is that they have different professionals who should ideally work together in a multidisciplinary way. The short answer is that I would suggest that the first port of call, if it is not too severe, and again, severity can be one index. If you're going through a mood problem that is causing a lot of dysfunction, then I would not even wait to see the therapist. I would see the psychiatrist first. Having said that, if you find yourself talking to a therapist, you're not getting better after a few sessions, you can broach that topic with the therapist and ask the therapist, do you think I should be referred also to a psychiatrist? Okay. If the therapist is not agreeable and you still are not feeling well, I think you should get an opinion from a psychiatrist.
Right.
and then put it all together.
And at this point, then I would like you to talk about the role of medication and
Sure.
how that plays out.
So now the point is, when do you use medicine and where do you use medicine? There are some cases where clearly the psychiatrist's opinion from the experience and the severity of the diagnosis will be such that you say that, look, in this case, without medicine, therapy is not going to have much benefit. At this point, it's important for the patient, for the person, to get all the information about the risk versus benefit, to ask what are the side effects, how long do they last, what is the long-term implications of taking this medicine, versus what is the long-term implication of not taking the medicine and of suffering this condition for years. Most medicines we use today for depression and anxiety are actually very well tolerated, meaning that side effects are fairly minimal. They can be used and are often used for long periods of time. After a person has been diagnosed with depression, the medicine has to be usually at least continued for a period of 8 or 12 months. 8 to 12 months after they are better. So it's not a quick fix. And the reason is, we know from research that the brain is affected in depression. There's actually degeneration of nerves in depression. We see atrophy, which means, a decrease in thickness of various size parts of the brain. And we know that with time, with treatment, it actually regenerates. So it's a real thing. So the first thing is that have a good discussion with a psychiatrist. Do not be averse to medicine from a purely ideological standpoint.
A lot of people, eventually get to that place where they are, they've acknowledged the fact that there is mental illness, etc. Medicine has been prescribed, and then it happened with me also. And then you reach that stage where you're like, there is stigma. Why is that?
I think there's a primal fear, because our personality, who we think we are most attached to our mind. When you give me a medicine for my heart, I don't feel as if it's going into me per se. You know what I mean? We are very scared about something that interferes. We think, people think, it's going to interfere with my mind. It's going to make me into something else. It's going to make me a zombie. It's going to take away my personality. It's going to numb me. It's a happy pill. It's going to boost my feelings artificially. These are the misconceptions that people have about medicine. And it's not symptomatic. It's not about giving a medicine to numb you. There are certain key brain regions that are malfunctioning in depression. They've changed the way they function. For example, the part of the brain responsible for motivation and energy is decreased in activity. The part of the brain that is causing fear and threat is increased in activity. Can you imagine what that's like? And that's what people don't understand. If this part of the brain is increased and you go out into the world, you will see more threat because your brain is like that. You will not feel as motivated. Life will seem like a burden because these neural structures aren't working. And medicines are to restore normal function. You will still feel sad when you have to feel sad, because depression is not sadness. You won't feel artificially happy. You're not going to be a zombie. And so, at the same time, I do agree. And I have to say that we don't want to be a country, in my opinion, like America, where there's so much emphasis on medicine, but not enough on other things that we... Yeah. Here we have the opposite problem, where a lot of people who need medicine, and I'm just going to say this, it's not just them. They have to fight with their own minds about stigma, then their family,
yes,
their friends, the pharmacist at the shop, even other physicians who, unfortunately, in medical school, you have no exposure, almost zero exposure to psychiatry. Other doctors have told patients, saying, why don't you manage on your own? So clearly, this sort of misconception and stigma about medicine is deeply ingrained in our society, and we need that balance, saying, yes, it's life-saving. It is absolutely going to save lives in the right cases. Do not allow someone to suffer needlessly.
Right.
I think the conversation needs to be grounded. What we need is, there seems to be binaries in this, medicine or no medicine. Whereas I think and this is not our fault also as professionals. It's just generally how the conversation has been. And I think we need to actually shift the conversation away from that binary thing to saying, look, medicines are part of a treatment plan. Yes. And different people's illnesses are different, and there are different stages of the illness, And at that point, different things are likely to be required and will work. And medicines then form one part of that entire treatment plan for that person, for that illness at that point in time.
Fine. Before we wind up, I had one last question, which is the role of the media. And I think I'm going to be a little more specific. I think the media we've seen increased increased amount of reporting on the importance of mental health and mental illness, I'd say, in the last couple of years. But I'd say specifically with regards to suicide, what do you think the role is of the media when such news is being reported? Dr. Soumitra, would you like to take on?
We've been harassing the media, as you might put it, for the many. There are very clear international guidelines. There's also the Press Council of India guideline on suicide reporting. So there are guidelines in place. Many of us individually and organizationally have been doing trainings with newspaper, media organizations, with journalists and all, to try and improve reporting. But change seems to be not happening that dramatically or as quickly as it should have happened. So what was very interesting, I noticed in the last few days, was that it was the first time where I actually noticed a change. I saw journalists writing on social media saying, listen, I've now realized why I need to report this better, and this is the change I'm going to make. There have been 2 or 3 or 4 stories in the last 4 or 5 days where journalists have identified and said, look, I did this story on suicide and I've looked at the guidelines and I'm doing a better quality story. Have a read at it. Which is amazingly a huge improvement, that people are actually making that shift. And I think that's what happens. Sometimes there is an inflection point. It sometimes takes a tragedy for change to happen. That there is an inflection point in how media is reporting. Now, that won't mean that tomorrow morning everything will turn out perfect, but I sense that there's a shift this time, that there is a reaction in the media to media, which is changing. But also, it's paradoxical when we talk media. We from the health space tend to chase the print media. We've been doing all our work with the print media. Actually, the bigger influence and the ones who do a worse job are the television media. The television media do a worse job of it, and they have an even bigger influence, because compared to how many people read newspapers, there must be 10 times the number who watch television. And somehow getting television media to change their ways is actually harder, and we need probably a more concerted campaign aimed at them. And the third group, which again is media for me, are all these TV serials. The TV serials also portray a lot of bad messaging around mental health as well as about suicide, and very often very regressive messaging. If you go and complain to media, whenever I've complained to even filmmakers about it or something like that, and say, look, you don't, this is not a proper representation. And I'm always told that these are artistic licenses that we take. We want to make a point. And so we are trying to say it in a certain way because we want to make a point. I think this was an argument which was even made in the past, say with smoking. Okay. Like media, I don't know if you remember, but the film industry also actively opposed the idea that we shouldn't have smoking on screen, for example, because, this is interfering with our artistic freedom and all of that stuff. And I think the same thing needs to happen with suicide and with mental health, because today when you talk to directors, film producers, TV producers, they will always take this attitude that, look, you can't curb our artistic freedom. You can't tell us this politically correct stuff that we should be saying. We are trying to express a story and all that. I think we'll have to actually engage with them to say, listen, there are many ways of telling that story. Just like with the smoking
You were saying on the media front, it's not just print media, it's not just electronic media. Yes, they also have a responsibility. Social media is a new angle, and then of course you're talking about film and television.
Yeah, especially the serials. I mean, I think we need to really target the serials, because they are like on a day in and day out basis getting into people's minds, and what they are actually promoting or talking about can have a huge influence.
Sure.
And so I think, and the film industry, obviously. But I think some kind of a dialogue needs to be established. I'm not in the mood to kind of turn around and say to them, censor them in any sort of way.
Yes.
But to actually say, listen, can we have a conversation? Can we
Can
start
we do
getting
it in
into
a way that is fruitful to everyone involved?
Exactly. Yeah. So that it's not like I'm telling you what to do. That's not
Right.
my intention. I'm
Right.
not trying to tell you what to do. You know your job better. I'm
Right.
just trying to tell you what are the outcomes and impacts of what you do on
Right.
society, and can
Right.
we do something different? Yeah, that's how I would look at it.
Thank you. And just to wrap up, what is that one message that you would, sort of leave us all with? One message to someone who's experiencing mental illness, one message to the caregiver, and one to community at large.
So to the person who's experiencing emotional distress, I want them to know firstly that you're not alone in this. Two, that there's nothing to be ashamed of. This is not your fault. This is not a weakness. This is not something that you brought upon yourself. And so once you understand that, you can seek help because this is treatable. So don't hesitate in getting professional help. To the caregiver, I would say, do everything possible to listen, to understand, to support, and to navigate the mental health care system, to help that person seek help and to be that source of support for them during that time. And to society at large, I would say this is the most urgent issue of our times, that depression and suicide will be the single largest reason for morbidity and mortality in a decade's time. It's already happening. We're getting there. And therefore, it means that everyone in society has to engage: policymakers, parents, teachers, employers, employees, family members, and everyone. So once we know that this is not about someone else, it's about all of us, we are part of the solution, then I think that will make a profound change.
Thank you. Dr. Soumitra?
Yeah, I'm not going to take long. I just think that one of the messages, really strong messages that needs to go out is that suicides are preventable.
Yes.
250,000 Indians should not be needlessly dying every year. It's something that we just can't afford to do. And the pain and the suffering that the families go through is something that we need to kind of avoid. And if we as a society and if we as a community got together, then I'm sure we can do a lot to bring these numbers down significantly enough. And suicide is one thing where every life saved is a huge thing. It's one life, it's huge. It doesn't have to be just numbered.
Yes.
So I think we really do need to kind of stop being fatalistic about this and really do something to say, demand why people are not doing enough to prevent suicides.
Great. Thank you. I think this
Thank
was
you.
a very, very insightful conversation, at least for me. A lot of my, I think, doubts, questions that I had have been answered. So thank you so much for that. And thank you so much for your time. And most importantly, thank you so much for what you do every single day.
Not at all. Thank you so much.
Thank you.
It's always a pleasure talking to you.
Thank you.
Thank you.